Keep your best years ahead. Longevity Roadmap with Dr. Buck Joffrey.
Welcome back to Longevity Roadmap with Buck Joffrey. I am Buck Joffrey, and today, a great interview we are going to have here with Professor Andrea Maier. She's an MD, PhD, a world-renowned expert in geroscience and healthy aging. She is the Un Chu Sang Professor in Medicine at the National University of Singapore and Professor of Gerontology at, I'm going to destroy this, but Vrije Universiteit in Amsterdam. She's has over 440 peer-reviewed publications, has made significant contributions to our understanding of aging mechanisms and age-related diseases. And her research focuses on developing diagnostics and interventions to optimize health and bring them to clinical practice. She's also the co-founder of the NUS Academy for Healthy Longevity and the founding president of the Healthy Longevity Medicine Society. She is at the forefront of translating aging research into practical applications for extending health span. Dr. Maier, thank you so much for joining.
Thank you for having me. Interesting to see what kind of question you're going to ask.
Yeah, I'm a physician, of course, and my own background lends itself to, I also have a degree in biochemistry. And so I got very interested in this space, at multiple levels. And so this podcast in particular, there's a lot of people who are interested in the science behind the stuff. So we'll talk a little bit about that. But first and foremost, I guess what initially sparked your interest in longevity research? What was your journey in this field over the years?
It's a journey. I started to be interested in research, but as a medical student, I was not really aware that aging exists. I know, of course, aging exists, but that the research would exist. And by being triggered through my life by seeing individuals who are very, very old, centenarians, who are very active and who are very powerful in bringing their message across. Me, for example, as a young child sitting next to a 100-plus-year-old lady, trying to help me to play the piano, that triggered my interest. Okay, what is aging? What can we do? And I really learned during the medical studies how to do aging research, and then I never left the field.
Yeah, interesting. Where did you start? Where did you were in medical school in Europe? What brought you over to Singapore?
Two different questions. So I grew up in a practice of a family physician. So my father and my mother had a practice. So I was always exposed to patients. I grew up in the waiting room. By the way, I think no medical practice should have a waiting room anymore. But I grew up there. I went to medical school in Germany, in Halle, then Lübeck. So I moved a little bit throughout Europe too. I love to travel during that moment in time. Then I went from the Netherlands, where I had different positions, to Australia for 5 years, and I was recruited to Singapore a couple of years ago. But there was already a relationship with Singapore. And why Singapore? Singapore is a great state, 40 by 20 kilometers. It's an island, great opportunities. The lifespan is long. The health span is okay. And there's a low fertility rate, which means that Singapore is really investing into healthy longevity.
When you look at geroscience, as a researcher in geroscience, how do you define healthy longevity? And why is that concept important?
So 10 years ago, even 5 years ago, I would always have talked about longevity. So how long you live. But there's really a switch into, it doesn't really matter how long you live. I still remember when I became a professor a long time ago, that the header on that newspaper was, Andrea Maier will make sure that you are being 130 years old. Of course, that's not what I want. It's not about the longevity in itself. It's about the healthy longevity. So we have two different concepts. We have the lifespan. So this is the number of years we are here. And then the health span, how healthy we are. And that switch from not only the time but the quality of time is really occurring worldwide. And so healthy longevity is nothing else than extending the health span. There was optimizing the health of individuals. And then I think we shouldn't go into the discussions of the WHO. What is health? What is really healthy? Because we haven't defined that, I think, very, very well. But for me, it's having a very good quality of life, being able to do what you want to do and avoid age-related diseases.
Yeah. And to a certain degree, I've always talked about that as in terms of the term health span, right? As opposed to lifespan. But to a certain degree, when you improve health span, you inevitably do get some years as well. It seems to me, maybe, if you're talking about somebody who is avoiding a myocardial infarction because they've lived a metabolically healthier life and they're not developing disease at the same rate, or somebody who's not developing Alzheimer's at the same rate is probably inevitably going to live longer as well.
Yeah, you are right. I always sell it a little bit. The extension of lifespan will be the side effect of increasing the health span. So,
Right.
but what we want to do, of course, is we call it compression of morbidity. So you have a certain number of years in health, if we dichotomize health, and then you have a certain amount of a number of years without so much health, which are unhealthier. So if we can comprise that number of years with age-related diseases and bad function, that would be great. And there is very likely a side effect that we are living longer if we are extending the health span. But I would say that's a secondary effect, not the main purpose of it.
With your research, are you focused primarily on that health span, or do you also focus a little bit on potentially mechanisms by which you can significantly increase lifespan?
Yeah, absolutely. So I started as a geriatrician. I'm an internal medicine specialist and geriatrician. So I saw with individuals at the age of 80, 90 and really targeting their polypharmacy and make them better and do all the interventions. Then I moved, but why don't we start much, much earlier in geriatrics? I love this space, but why should we actually wait? So my target population in clinical practice, but also in research, is much, much younger ages. This doesn't mean that I do not treat all the individuals. I treat all of them, only adults, no children at this moment in time. It's a different story. I think we now discover, and these are the mechanisms why we age, and we are aging with every cell division. So everybody listening at the moment, yes, you are aging.
Yeah.
At the moment, nobody is escaping. And understanding that, how to not only measure who is aging how, but also what we can do about it to be really ethical, to do something. That's what I do in research and in clinical practice. So my group at the National University of Singapore, but also in Amsterdam, yes, we are working on the mechanisms, understanding the how, and then implement it into clinical practice, into really change in the individual's lives. And that's what I do in She Longevity.
So if we want to focus our discussion maybe a little bit on the biological mechanisms of aging, what are some of the most, I guess, promising targets for interventions and strategies?
So very often what we do, and of course that's also appealing, is we are jumping into interventions. So what can I do? So what should everybody do? That's very often a question I get. And then I go back and say, hey, maybe let's first see, what do you need? And there we bring in precision medicine. And that's what we do in healthy longevity medicine at this moment in time. So the first step is, before saying what kind of targets mechanistically, is how are individuals aging biologically? So we have, think about 100 people in a room. They all age differently in terms of their pace of aging. So we know that the pace, so the speed of aging, is different in individuals. But what we discovered in the last 3 to 5 years is that within a body, so within one individual, me, for example, my pace of aging is very different in different organ systems I have. So in my heart, in my brain, in my skin, in my eyes, these are all the organs are having a different pace of aging. To make it a little bit more complicated, and is that not only that the pace is different, but also the mechanisms why that organ is aging might be very different. So I might have a telomere problem in my heart, and I might have how we fold proteins we need in my brain. So this discovery is happening at this moment in time, that we understand how do we age, in which organ, and then we are matchmaking that with a target, with an intervention. And think about enlarging telomeres, think about folding proteins better to avoid diseases. Think about really improving the epigenetics, improving the microbiome. So we all now know how to measure. So we already implemented that into clinical practice. And now we are finding the targets, how to treat individuals, you differently from me, differently from your neighbor, to give that anti-aging intervention, or I would call it healthy longevity medicine intervention.
Give me an example of something like that. When I've been following this space, at least from the basic science side, I mean, certainly there's different speed of aging of organs, but I think a lot of people are sort of using the assumption of this universal loss of information theory that came from the Sinclair lab. Are you using that sort of as a foundation, or are you using something else?
So what we do in our lab is really looking at the accumulation of damage and the repair. So there are different theories, and I think we cannot prove which one is good or not. But what we know is whatever we use, including our body, we are accumulating the damage. So if you're looking on the cellular level, we see that there's DNA damage. So we can test that. We know that the telomeres are being shorter. We know that the mitochondria, which are producing the energy, are not only in number decreasing, but also their phenotype, how they look like, are changing. So we can now pinpoint to certain primary causes, which then lead, for example, to cellular senescence. So we now disentangle the 12 hallmarks of aging, which are telomere attrition, so not good, having mitochondria, and proteostasis, which the proteins cannot be folded. So we now know how to measure it, what they do, and now we have sequences, and we see this is leading to that. And one of the very exciting things I think we discovered in the past 10 years are senescent cells. So senescent cells which are accumulating. There's even debate if they're accumulating or not, but for me, there's a higher number of senescent cells in older individuals. We can detect them, we can measure them. So if we take a sample out of an organ, we can see them, that they are higher, and we can now actually get rid of them. So that's one of the targets also in pharmacological research, is senolytics. So senos is old, and then lytics is getting rid of it.
Sure.
One of the examples. But what we learn is not only that the organs have a different pace and that the mechanisms might be different, but also if we are looking within the mechanisms, that they are working together. Everything communicates with each other. So the immune system and the immune cells with senescent cells, etc. And that's so exciting. So we are looking at a picture, a network of dysfunctional communication very often at older age.
What are some of these interventions? You talk about, poor protein folding, and obviously that's a big problem, but it is a problem generally, I would say, again, of aging genetics, or poor expression of those genes. Like what do you do, or poorly differentiated proteins?
Yeah, so that's a very specific problem. I think nobody solved it. I think we will get the Nobel Prize if we do it. So maybe we can do that in this show.
I guess I was under the assumption that you were saying that you were targeting these different things individually. So that's why I was surprised to hear that.
No. We can measure it. So we know the proteostasis, autophagy, for example. So we even know, but this is all still in research. So there is no drug now doing that. And think about protein folding diseases like we see now in Alzheimer's disease, but we also see that in Parkinson's disease. If we could really find that and how to target it, we can measure it at this moment in time. But the question is, can we intervene? But to give you another example, we know that mitochondria, which really have to bring the energy to the cells, and we need that at this moment in time always, if we are on the treadmill, we know that mitochondrial function is going down. There are molecules we now can detect, for example, NED levels, which are in mitochondria, to really see how we can influence it, how we can pharmacologically influence it. For example, with nicotinamide mononucleotide, with other vitamin Bs. So we know if we have a target, how to interfere. If you ask me at what stage is it, I would say compared to what I do in clinical practice in oncology and endocrinology, we are at a start of understanding how to intervene in the aging process. But we already have targets like supplements, repurposed drugs. We know how to and when to give drugs like metformin, etc., which might have a pleiotropic effect to really optimize the health of individuals.
What are you interested in terms of some of the promising future interventions? What do you see coming down the pipeline that you're excited about, that might be accelerated maybe with some of the technology that and AI that we've got? I mean, what are some of the real problems that you're excited to see potential solutions to?
Yeah, many of them.
Yeah, sure.
Many. So there are so many drug targets now coming up to actually see if we are giving the drug target, or a drug, if we really can improve with very objective biomarkers that we are optimizing the health. So it's think about the stem cell theory. So we have the opportunity to actually show that stem cells might influence positively if we give it to individuals, the health of individuals. However, it has to be proven. I'm a little bit cautious here to talk about it because there is no evidence at this moment in time that stem cell therapies, giving stem cells to aging individuals, that will be helpful for these individuals, because there are no randomized controlled trials in middle-aged individuals which are well conducted that we have any evidence. But theoretically, thinking about that the stem cells are being exhausted during the aging process, helping them, giving them a better environment that they can flourish, giving a little bit more of them, theoretically would work. So I'm really looking forward to these kind of technologies to even test if it's going to work and make it more specific. Because a stem cell, for example, is just a variety of cells. Can we even be more specific to give personalized the molecules, the cells, the environment, what a person needs? And that brings me really to the exciting thing we do with others around the globe, is bringing precision to our approach. Very often health and longevity medicine clinics, they are operating at the moment as an a la carte service. So what do I mean? Like, think about, you are going to a restaurant, you say, I want this meal, and you get it. Of most of the times you get it, if it's not sold out. We do the same very often in the space of health and longevity medicine. I want a drip. I want the stem cell therapies. I want the plasmapheresis. I want this and that. We have to be more precise, because a client, an individual, a patient cannot decide what is actually needed. We have to matchmake it. What is the need of that individual during the aging process? And then advise what to do. And that's what we are implementing into clinical practice, to really make it medical, to take it seriously, and therewith to have better outcomes.
So I know you're, obviously very well published. Your work involves a lot of international longitudinal cohort studies. What have been some of the most surprising or significant findings that you've seen from these studies?
The most important studies we do at the moment, which help me in clinical practice, is measuring individuals' age. So saying to individuals, and that's what we learned out of cohort studies, how old somebody is. So really disentangle the chronological age with the biological age. And then even going a little bit further, what we just discussed is that organ age, and then the question why. The other thing, what we are doing at the moment, we have great results, is doing randomized control trials. So what does it mean? You have a bunch of people, you are separating them. One part receives a placebo, and the other group receives that treatment. And the treatments we are focusing on are drugs, they are supplements, they are combination therapies. I think there is a a huge discovery which will come in combining therapies based on the needs of individuals. And what we were able to show is not only the mechanisms, for example, that senescence really matters in aging individuals, where senescence is occurring, how can we remove senescent cells, but also now implementing that knowledge we got out of our research into clinical practice, and to actually see what the need is of individuals to democratize what we do, not only the implementation, but the bringing it to entire nations. And that's the reason why I'm in Singapore.
Sure. So you've published extensively on diagnostics and interventions for healthy aging. So I guess from a listener standpoint, what are some of the practical steps that they can take to assess and potentially improve their own biological age?
Great question. I love it. So first of all, get to know yourself. That's most important. So I will not ask you what you know about yourself, but every listener, just think about, do you know what your genome is? Do you know what your microbiome is? Who are your friends in your gut at the moment? Do you know, or not your friends, but then make them your friends?
Right.
Know what your habits are. So tracking devices like smartwatches, smart rings are so available. Using them yes, very good. Using them not only as, okay, I'm trendy, I do it, but acting on it is so important. I think if you have the means to do it, not only track yourself, but seek advice. So go to individuals in the space in healthy longevity medicine to really optimize based on what you already have and knowing yourself, optimize the interventions. I think the greatest advice I would give to individuals is treating yourself not as a snapshot, but as a story. What I mean with it, tracking yourself over time and realizing how you age and what the pace and the way of aging is. It's not only tracking a weight, because that everybody can do, which would already be very meaningful for populations, but also tracking your sleep, understanding the interactions is very important, because even looking at pictures now from yourself and 10 years ago and 20 years ago, and then seeing if you want to do something about it.
Yeah. I look younger.
I won't ask you what you did.
I've been on a lot of, I do probably a lot of the things that you talk about, with the diet, exercise, sleep, and all the supplements, and gosh, who knows what else. But, I'm a physician who kind of practices on myself. I'm my patient right now. I don't have any other patients. So,
yeah. So, but I think this is all great, and everybody should do it. And I think bringing the knowledge to the listeners, bringing your knowledge to everybody is so important. I think what we have to learn, how do we make it more precise, that all the efforts you do are meaningful for your body and for your soul and for everything you want to do. And I think there's a great learning curve at the moment. Who needs what supplement? Who needs what intervention in terms of diet? Because we already know that certain diets, certain physical activity habits are not good. It doesn't mean that it's harmful, but it might not have the return of investment for everybody in the same extent. And this is so, I think, empowering, saying, hey, we have the recipe for you to get the greatest benefits with not only the lowest cost, but the lowest, I think, intensity of time you're investing.
I think that's the big challenge obviously you guys have a clinic out there, but even in the literature, when you look at, you're talking about cellular senescence quite a bit. And of course, there is a number of supplements that are supposedly senolytics. So, are you going to take spermidine, or are you going to take fisetin, quercetin, or you can take, so that's, I think those are a lot of the challenges. And then beyond that if you're buying supplements, you have to know that because, at least in the US, if something is not quote unquote FDA approved, you don't know exactly what's in there. Is it the actual supplement that is said, or is it just a sugar pill? So it's an extremely challenging space, and I'm hopeful that there is a little bit more clarity in the future.
Yeah, you're right. So first of all, there's not much evidence yet that all the supplements you just mentioned, that there is effect in humans. So very often we are basing it on animal studies. So be careful what you take. The second is combining supplements. There not much evidence in humans, and even not in animals, that if we are combining supplements to target 2 different pathways or 3 different pathways, that this is synergistic. So we are now starting the first randomized controlled trials in my group to give 2 or 3 supplements to individuals to actually see if we have an additive effect. So think about biohackers like Brian Johnson taking many of them. I would geriatrician, this is polypharmacy. Don't do this, because we have no idea how certain things interact, and it might be very, very harmful. The same for giving drugs. Think about metformin together with rapamycin, together with an ACE inhibitor for healthy individuals. We have no idea what that if that's meaningful for the body. And I would rather think it has side effects. I never do that in clinical practice. The third thing you touched on is the quality. We did studies buying many bottles of supplements, including uracil A and nicotinamide mononucleotide NMN. And we were actually showcasing that only 20 to 30% had actually the supplement inside, and the content which was written on the bottle, and many had nothing inside. So there is a quality problem in our field.
Yeah, absolutely. Speaking of Brian Johnson, I was mentioning to you that I actually got myself to watch the Netflix thing yesterday out of curiosity, and sure enough, I saw you being interviewed on there, and I was like, oh my gosh, I'm interviewing her tomorrow. That's funny. So you had a chance to I guess treat Brian Johnson, and I'd be curious more on your thoughts on that. But one of the things that I noticed there is, I think, somewhat related to what you just mentioned, which was he's on so many medications, supplements, and some of them at even, for example, even the dosing, it was really concerning in a way. I mean, I take rapamycin, for example, but I think he was taking something like 15 milligrams or 15 milligrams or 17. He was taking that, and then he was taking a bunch of stuff that arguably, that would be counterproductive. For example, I think in there he mentioned he was on growth hormone, and IGF is probably one of the things that's going to shorten your life, at least from the data that we know. So comment on that for us. I mean, obviously, I think Brian is trying, and I don't think he's doing anything wrong. I think he's really trying to do something for humanity. But I'm just curious on your take with that experience.
So I always have an approach that I give interventions if I know that a person needs it and I have something to measure the effect. So because I not want to know if it works. I'll give you an example. If I see a patient with diabetes, I can measure the glucose level, I give insulin, and I measure the glucose level again, and I know it works, or it doesn't work, and I can titrate how much of the medication, insulin, this is example I give. So the same principles I apply in clinical practice when I treat individuals who are aging to optimize their health. So Brian Johnson is doing so many interventions that it will be very, very hard to measure any effect. So which does what? And I think here is a problem. If we are looking back in modern medicine, we are, for example, in oncology, if we have cancer patients, we have trials where we say this medication plus that medication has a greater effect. And considering the timing and considering the dosage. And that's what we are learning at the moment in the health and longevity medicine field. So in clinical practice, I am only considering to give multiple treatments, and it can be drugs, it can be supplements, if I can measure the individual effect. And that can be in sequence. We are starting with one, we are giving another one, we are seeing if there is an additional effect while tracking. And this is very important. All measures we have in hands continuously. For example, with a ring, with a smart ring, the temperature, the heart rate variability, the sleep, and to see if these can be surrogate markers for showcasing that it has a positive effect. So I think Brian Johnson, as a biohacker, has an enormous positive effect to the field, really showcasing that we can change our body, but it can be hugely detrimental because there's no evidence that this regime actually helps in many people, and it might have a huge number of side effects. So very often in clinical practice, biohackers come to me and say, Andrea, can you actually help to de-prescribe me? So what should I stop first, and how can we evaluate one or the other helps? And I think that's a question, I think, which is very valid, how to de-prescribe. And that's what we learned in geriatrics, really showcasing, okay, this is what you need at this moment in time and this dosage, and helping individuals to optimize their health.
There are some things that it seems to me it might be kind of hard to see if there's any benefit at all, though. And you certainly I brought up rapamycin. Rapamycin across species is probably the drug that has had consistently the most positive benefit on lifespan. But we don't have human data on that. And, maybe you do. Maybe you could tell me about that. But I guess, how do you measure whether rapamycin is actually doing anything positive? To a certain degree, at least for me, I'm taking it based on a little bit of a leap of faith. I pulse it once a week, so I can try to, inhibit the right parts of mTOR, and all this stuff. It's a little bit of a guess. It's a lot of a guessing game. And so how do you evaluate those kinds of things? Or do you not do them?
Great question. So it's estimated that hundreds, thousands of individuals for the purpose of health and longevity already take rapamycin, whereas the evidence in humans, it's quite limited. So we summarized the evidence last year, and there were 15 randomized controlled trials in humans with different dosages. So as you say, once a week, or on lower dosages once a day, really showcasing in that systematic review that it has positive effects on the immune system, and it could have positive effects on the cardiac system. But what we actually found is that many of the organ systems, are not even measured, and that we do not have real good results on middle-aged individuals. So very often older individuals with sometimes even frailty were included. So the representativeness of the population is also questionable. So we are embarking on the longer study, so rapamycin 6 milligram per week. Our primary outcome is immune function and inflammation, but we are measuring the entire organ system, so including hair, including skin, including cognition, etc. So what I would advise to do is, because there is such a absolute understanding that rapamycin interferes with the immune system, measure, for example, CRP. Your C-reactive protein should be very low, under a 0.5, for example, to really make it low. So there we have measures. But measuring with a Western blot mTOR and then complex 1 and complex 2 in clinical practice, absolutely not doable. So here we really find surrogate markers to see, is there an effect? And that's the reason why, before starting a treatment, is measure before surrogate markers. So measure inflammatory markers, measure how much immunosenescent cells somebody has. So these kind of assays are available now, not on a mass scale, but in different labs. You can do that and be guided by longevity physicians, and then measure the effect after. Depends on the treatment. For example, rapamycin, I would really wait for 3 months, and also look at possible side effects. Like we know that 30% has mouse ulcerations, not being talked about so much, but there can be a huge number of side effects, and then see if it's really worthwhile to continue.
Yeah. Yeah, sure. Do you have, I'm just curious. I mean, there's also the TAME trial now with metformin. Do you use metformin frequently as well?
So the TAME trial really originated by a great idea from Neil Barzilai and other colleagues from the Albert Einstein Institute in New York. Great study design. Hasn't started yet. It's really a landmark study in terms of especially starting the discussions with the FDA. Metformin is a great medicine I use very often in clinical practice, and now we are learning how to use it for the purpose of healthy longevity. Lots of pleiotropic effects. Can also have side effects, gastrointestinal side effects, but great. I think if you would ask me, should I start? How much likelihood do I have that I'm living longer? We do not know, but great molecule with lots of experience, so that we actually know that how much side effects to expect. And because that's always for clinical practice, as you know, as a clinician, we always have to weigh, you're doing something, how much side effects do you expect and how much effect do you want to have? And weighing that is of importance.
So obviously, as a researcher, you've got a lot of challenges with translating longevity research. I mean, that's fundamentally, I think, it's hard to do trials on humans and determine how long they live because we want to try to figure out the answer before we die, right? So talk a little bit more about the hurdles in longevity translational research and maybe how you try to overcome some of those.
So first you need finances, money to do it, okay?
Yeah.
And there the landscape really changed because trials, very often people think, oh, I just do a trial. Like I, as a trialist, it's hard. So you first need the money, then you have to do it. You find individuals, and then you are implementing, which is also a trial, implementing it into clinical practice. So, but first of all, and I really want to get the message out, it's absolutely doable to do human trials. I never touched a mouse in research. I only do human research because this was the missing link 10 years ago or 20 years ago. Now, many more studies are being done in humans. It's absolutely doable. We have the capacity to do it. We have participants. Like maybe you would love to be in a trial. We have participants who see it. Yes, I see the need. I want to contribute. It's absolutely doable, but we need more and more and more. Then the question is how to translate that into clinical practice. And for me at the moment, it's very easy because there is a parallel process of translating animal studies into human studies to showcasing, yes, this supplement has effect or no effect, rapamycin work, doesn't work, and whom, and then bringing that into clinical practice because there's a growing number of clinician scientists, as I'm working at the university. Yes, I have clinics, and we can implement it. So the question is, how do we scale that, and how do we make sure that if you are going as if you would as a sort of patient or client to a longevity clinic, that we know that we have a quality control system in here. So that's the reason why I founded the Health and Longevity Medicine Society, and that brings healthcare professionals together, not only building the network that we can talk together what we do, but especially that we are writing guidelines. So how do we apply and give for whom, for example, rapamycin? What should be the dosage? What should be what we are measuring? And how do we determine if there is an effect, and how long should we actually give it? So this is so powerful that we are now growing from, we have ideas to optimize the health as individual healthcare professionals. We're now growing into something which is a network, building guidelines to really optimize the health in a standardized way, with evidence.
Where do you find those kinds of guidelines? I mean, a lot of people probably don't even know that they're out there. I didn't really know that there was out there. I happened to be taking 6 milligrams a week of rapamycin, just like you said, but where are they?
So the guidelines, so now I'm talking to healthcare professionals because we don't write guidelines for
Sure.
The clients, a layman. So Health and Longevity Medicine Society is hlms.co. Become a member, become part of it, and there are guidelines, working group commissions who do it, and then we are releasing it. The first guideline was released in October last year, and we worked together with the Department of Health Abu Dhabi, the Institute of Healthier Living, together with Health and Longevity Medicine Society, and wrote actually what kind of diagnostics and therapeutics should a longevity clinic do. And that has been signed off. It was a huge milestone for the field in October last year, and the first certified clinic in Abu Dhabi was signed off in November, which is great, because then also from a consumer perspective, consumers know, no, I go to certified clinics, which are actually hopefully knowing what they're doing. I know that there's a quality process behind it.
Right.
It has been signed off by, for example, departments of health. So we are writing at the moment guidelines about HRT, hormone replacement therapy. There is a guideline group finishing very soon. Should epigenetics being used? What kind of algorithms should we use? What kind of epigenetic clock should be used? And there is a consensus there from healthcare professionals together with other stakeholders what to do. And there was advice, and then we have standards and we can measure.
Wonderful. Well, Dr. Maier, I really do appreciate your time coming to us from all the way across the world there. And I would love to have you on again sometime.
Thank you so much. Next time when we are on, I would really love to hear what your blueprint is.
Oh, you bet. Easy.
A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe.